So there's another one I presented last week. I'll go through it pretty quickly. This is a 76-year-old male with low back and right lower extremity radicular pain in the L5 distribution. He's noted increased symptoms for about 3 to 4 months in the past. He notes that about 25% of his pain is in the back and 75% in the right lower extremity. His examination, neurologic examination, is essentially normal. These are his x-rays. You can see he has a degenerative spondylosis in his lumbar spine with multi-level disc degeneration. He has multiple areas of, stenosis, a little bit of facet hypertrophy throughout at every level. At his L4-5 level, he has significant right-sided neuroforaminal stenosis. He also has a disc extrusion here that can be seen on the parasagittal, and he appears to have a small far lateral disc extrusion at L5-S1 as well. So the options we considered for this gentleman were observation, which he did not like. He's having significant pain for a couple of months, and he had failed conservative measures versus a decompression type procedure. We ultimately went with a minimally invasive right-sided L4-5 laminotomy and microdisc, as well as a minimally invasive L5-S1 far right discectomy for the far lateral disc herniation. Did someone say something? Okay, I'll keep moving on. So I just wanted to talk about, tubular discectomy versus conventional microdiscectomy. I think this is, for these very small procedures, these are kind of the areas where minimally invasive surgery versus conventional become a little more equivalent. This is a double-blind RCT out of the Netherlands that looked at 5-year outcomes, early, intermediate, and late outcomes in patients that were randomly allocated to undergoing tubular microdiscectomy versus conventional microdiscectomy for lumbar disc herniations. They didn't find any difference in disability scores at 5 years or leg pain and back pain. They did note that there was no significant difference between patients' reported improvement compared to their preoperative symptoms, and the reoperation rates were 18% in the tubular group and 13% in the conventional group. So it was not significantly different between the two groups. So I think this is the imaging basically showing the same. All of the patients that were treated surgically improved compared to their preoperative symptoms with regards to their disability scores, leg pain and back pain scores, but they were not different at any time points from a couple weeks following surgery all the way out to 5 years. So I think, the ultimate conclusion here is that it's really a dealer's choice based on the surgeon and what the patient wants. And I think a tubular microdiscectomy versus a conventional microdiscectomy they're very similar procedures, with different instrumentation. There is a little bit of theoretical benefit of muscle sparing along the spinous process. In my mind, I think the benefit of the tube for the far lateral decompressions is a little bit higher, makes it a little bit easier in terms of the retractors, but I kind of want to get a sense from the group as well.
I think that's right, Dan. None of the studies have demonstrated any significant difference at a year. There's a few from the US that have shown differences at 3 and 6 months, but those were kind of predictably authored by people that advocate for the tubes. So I think you just got to get the job done, and you do the best you can in your hands.
I think that Andy hit it right there, which is like, you're looking at, at a 1 or 2 year improvement. That's not going to be different for an open versus Taylor versus a microdisc with a tube. At 2 years, the outcomes are the same. arguably so even for just non-operative management, like for a disc herniation, for instance, right? So it's gonna, if you're looking at studies at 1 year and 2 years to see how patients do, I think you're missing the point. And to me, these are studies that need to be comparing, narcotic use early on, and then like how is day 7 versus 14 versus 21. So I think that's probably where you'd see a difference, perhaps potentially, is just because I think the theoretic muscle damage is less than one versus the other. But that's probably, with healing of the tissues probably goes away pretty quick as far as the true advantage of it. So, and you'd have to, your numbers, to power that study, you need a lot of patients, right? You can't look at 50 versus 50. You're looking at thousands to try to find that difference of 1 or 2% that may exist early on.
Yeah, this is Calm. Also, I have a comment regarding this. Just when I was doing these personally, I felt like you oftentimes have to take a lot more facet when you're doing it with the tube than not. Have there been any studies with the amount of facet removal comparatively of the two? And I think that'd be the reason to do more 3 and 5 year studies too, to see if there's any increased instability over time. Because I think you can get more discectomy and more access a little easier without the tube sometimes. Without.
So you're saying, Cam, that you find that more facet is taken when you're using the tube because you don't have great visibility.
I agree, because for example, using a McCullough or anything else, you can kind of get a more, because you can take a little bit more bone medially, you can get a better angle and not have to take as much facet. And depending on patient's anatomy, a lot of times you can avoid taking any facet most of the time. And I found, like, when I was doing it with the tube, and also post-op patients and other folks that have had to revive, I often see that there's a lot more facetectomy done with the tubular ones. I don't know if that's anybody else's experience.
Yeah, I don't think it's been well studied, but I agree with you. I think the tube tends to force an angle of more lateral to medial, and that can harm you when you're, especially in the mid and upper lumbar spine, where you can't afford that. So I think you tend to see more joint taken, and it's a good question to look at the post-op instability patterns. But
it is a good question. I mean, even if you're doing it 3-4, to do it in a tube that's narrower than 18 millimeters can be kind of painful. And a lot of those lamina, are not 18 millimeters in width, especially, 2, 3, 3, 4. And so you're already kind of exposing a pretty significant portion of the facet with your tube. And, there's probably a tendency to take more of it than you should. Certainly on some of the post-op MRIs I'll look at them and be like, wow, that's more than I meant to take. So, and potentially,
we could do is it'd be really interesting actually, is to grab an O-arm spin at the end of your case.
Yeah.
That'd be kind of fun to do, right?
It would be interesting.
That sounds like a really fun 20 minutes of additional.
Yeah, it'll take about the same amount of time as my case.
I was thinking more of Bruffy's cases. Make him pay.
We'll have to have Hanny come in and decompress our subdural after we bang our head against the wall a few times.
Yeah.
Well, thank you, everyone. Those were good discussions. I'm going to hand it over to Rob now.
Yeah.